I'm going to duck out and join from the attendee page.
Hi, everyone. Jayajit, can you elevate some of the panelists to, I see them as attendees. Hello, everyone. You are not seeing the panelists quite yet. I'm Colleen, I'm at the AAG. We have had a few technical issues with this particular Zoom webinar, but it seems like everyone found the link now. We will elevate the panelists to panelists. And if you will allow us 5 minutes to prepare a little bit, make sure that all is okay, that would be great. So we will
All right, let's get started. Can you hear me, Colleen?
Yes, Sean.
Yes.
Thank you very much. Our apologies for the technical glitch with Zoom. And again, thank you very much for your patience and for your joining today's Geospatial Fellows webinar. And this is a webinar series. Now we're in the middle of the series. We have more very interesting topics to be covered in the future. I'll quickly introduce today's two fascinating topics. And my name is Xiaowen Wang from the University of Illinois, Urbana-Champaign. I'm delighted to facilitate today's webinar, and you could see the chat box as well as a Q&A. We would encourage you to type up your questions into the Q&A box as the webinar will progress. At the same time, if you have any questions or issues or opinions to be expressed, use the chat box as well. So I'm very delighted and honored to introduce today's two speakers. I'll start by introducing Dr. Jay Czechobody from the University of Texas, El Paso. Dr. Czechobody is an expert of GIS and environmental justice. He's a professor of geography in the Department of Sociology and Anthropology at the University of Texas at El Paso. His research activities address a broad range of environmental health and environmental justice issues. In particular, he applies GIS and spatial analysis techniques to analyzing environmental and social injustices. His research going to be covered today with the particular topic titled Vulnerability to COVID-19 for People with Disabilities, Spatial and Social Inequalities in the US. The second lecture will be given by Dr. Daoqin Tong from the Arizona State University. Dr. Tong is an expert of spatial analysis and GIS, and his research focuses on spatial data analysis, spatial optimization, and GIS to improve spatial decision-making. Her research specifically develops models and algorithmic solutions to solve real-world problems spanning location analysis, food access, and transportation, as well as public health. So her talk today is titled Transmutation of Food Access During the COVID-19 Pandemic. Both scholars are well known. Since we're falling behind, I'm going to cutting my introduction to be as brief as possible. So now I'm going to turning the floor to Jay. Please take it away.
Thank you, Xiaowen. And let me start by sharing my screen. And give me a second. Okay, so good afternoon, everyone, and thank you for coming here virtually today. And as you can see from the title, or I guess I should first clarify that a lot of my past research, as Xiaowen mentioned, has focused on environmental hazards, environmental health, environmental justice. So this is a relatively new topic or area of interest for me. So I'm really grateful to the Geospatial Fellows Program for selecting and supporting this project. And I'll begin with a little bit of background on disability. This is a complex and multi-dimensional construct that can be defined and studied in many different ways using many different frameworks and methodologies, which are not really related to my presentation here today. However, my project uses the census definition of disability, which has been around since 2010 census and also adopted by many federal agencies, I think especially in the last 10 years. And as you can see, this census definition is based on 6 self-reported types of difficulties. And the universe includes non-institutionalized civilians only. It does exclude those in the military and also residents of specialized group homes. And here are more detailed definitions of the 6 types of difficulty. Again, important to keep in mind that many individuals report multiple types of difficulties, so these are definitely not mutually exclusive categories. And according to the latest ACS, close to 41 million people, or about 12% of the 12.7% of the total reported at least one type of difficulty. And those with ambulatory difficulty represent currently the largest group, followed by cognitive and independent living. And historically, vision difficulty has been the smallest in terms of this percentage. And very important to understand that PwDs represent a highly disadvantaged group in terms of economic status. In an article published in the American Journal of Public Health in 2015, they were kind of categorized as an understudied group and an unrecognized health disparity population, which appeared, I guess, in the title of the special issue. Unrecognized in terms of several common health and social indicators they had used. And a more recent report from 2019, you can see the title right here, found huge disparities in both the poverty rate and employment rate between PwDs and the non-disabled population. And these gaps have not really decreased over time, as you can see from these line graphs right here. And also a journal article published just before the pandemic found PwDs to be 4 times more likely to get injured or die than the non-disabled during a major disaster or public health emergency. And then, of course, came COVID-19. And I think in late March of last year, the WHO released this 13-page document highlighting disability-related considerations, for the COVID-19 outbreak, specifically for PwDs. And this report did an excellent job at describing all the challenges and problems faced by this group, and which are kind of listed on the right of your screen. And you can see that this is a very comprehensive list, which covers barriers to accessing public health information, accessing healthcare, barriers to implementing basic hygiene and social distancing guidelines, as well as serious disruptions to the services that they rely on a daily basis. So this report and the lack of published research on this topic kind of motivated me to write the proposal for this project. And here are the broadly defined goals and research questions. Again, the main purpose was to apply commonly used and reproducible geospatial techniques to explore whether PwDs and those with specific types of difficulties are more likely to reside in COVID-impacted areas compared to non-disabled people, and also whether those at the intersection of disability and other social disadvantages are overrepresented in COVID-impacted areas. And I started by using counties as the unit of analysis for both questions. And COVID vulnerability was initially defined in terms of case incidence rate. I'll begin with a brief overview and just a few examples of how I tried to answer the first research question. And I started with a cluster detection technique that allows units to be classified as hotspots based on higher values relative to the study area. And in this example, the local Gettysord or GI star statistic that actually has been around for 25, 30 years almost, parameterized using Queen contiguity is used to classify counties into 3 spatial clusters at the 95% confidence level: hotspots, cold spots, and not significant. And the variable here is incidence or infection rates as of February 1, 2021, which is approximately 1 year since COVID cases have been officially counted or recorded in the US. So the next step was to compare the disability characteristics of these county clusters. And here's a table with the results based on the distribution of each group across these three clusters. And I found that counties in the hotspot cluster contain about 9% of all PwDs, but 8.3% of the non-disabled population, a positive difference of 0.7%, which was significant based on several tests I used. But people with the disability and people with all types of difficulty are essentially overrepresented in the hotspot counties, as indicated by these positive differences, and underrepresented in the cold spot counties, as shown by these negative differences when compared to those with no disability. I also examined if these differences have changed over time. So I redid the analysis for 3 more time frames, starting from May 1, which was approximately the first 3 months, then the first 6 months, 9 months, and finally 12 months, which you saw on the previous slide also of the pandemic. And interesting to see, of course, the spatial patterns of hotspot locations have changed, but in the first 3 months of the pandemic, PwDs were actually underrepresented in the hotspot counties compared to those with no disability. In all groups, all numbers are negative. But gradually after August 1st, or mainly after November 1st, when the hotspots spread out spatially or moved to the Midwest and the North and South Dakota, of course, specifically, the differences become positive for the overall PwD percentage as well as all types of difficulty. I also explored bivariate relationships between COVID incidence rate and PwD percentages using the bivariate Moran-Tsai, a very popular method for assessing spatial correlation or autocorrelation. And my blog on the Cyber GISX Hub contains more details on this part of the analysis. But I did find 269 counties to be located at the convergence of higher COVID infection rate and higher disability percentage, marked here in red or as a high cluster. And I saw that these are mainly, as you can see from the map, these are mainly located in the southern states and in predominantly rural areas. And to examine these urban-rural differences in this relationship, I used the official census designation, which classifies counties as metropolitan or non-metro, and then non-metro counties are further subdivided into micropolitan and non-core. I think the population cutoff is 10,000 people. But out of the 269 counties in the high category, almost 43% are non-core or highly rural, and less than 1/4 are metropolitan. And I also found that these patterns have not really changed over time, starting again from the first 3 months of the pandemic and going all the way to an ending at 12 months. In all 4 time frames, I found that more than 40 or 41% of counties at the intersection, again, of both higher COVID rates and higher disability have been non-core or highly rural, and less than, say, 20 to 23% are metropolitan. So from a policy perspective, these results clearly emphasize the need to focus on COVID impacts for the disabled in rural areas of the US. And my second research question sought to examine whether socially disadvantaged PwDs are more likely to reside in COVID-impacted counties. And this question is linked to this larger concept of intersectionality, which has emerged as an important research topic in recent years in many different fields. And even disability scholars have documented how social disadvantages such as minority or poverty status often combined with disability status to create a double jeopardy for PwDs, which could become like a triple or multiple jeopardy when you add higher COVID exposure in places where they live. So this led me to disaggregate PwDs using the latest ACS data based on these 5 characteristics or categories. And here are the subgroups that comprise these 5 categories. And for this part of the analysis, I used multivariable models or based on generalized estimating equations, which extend the generalized linear model to account for spatial clustering. And I think that this approach was very useful here because DEs relax several assumptions of classical regression, and also because they are more suitable for other modeling approaches like spatial regression, where clusters and neighbors are often defined somewhat theoretically or arbitrarily based on just contiguity or distance, not always based on theoretical or empirical considerations, which I was able to do here. So I used a combination of two different approaches to define clusters for this part of the analysis. The state was used as the first clustering variable because counties in the same state can be assumed to be similar in many different ways and different from counties in another state. And since the use of states as the only clustering variable potentially ignores intra-state variations, I also use the same metro, non-metro designation I was showing previously to account for urban-rural differences within the same state. So the combination of these two clustering variables resulted in a total of 107 effective county clusters. And here are the results from the best fitting models that are based on disability-specific independent variables and focusing mainly on the socially disadvantaged subgroups. So in all four models or timeframes, the overall disability percentage indicated a negative relationship with COVID incidence, but these beta values are significant and positive for PwDs who are Hispanic, Black, and female in at least 3 of the 4 timeframes. And then again, I found somewhat mixed results for age and economic status, although poverty level has been positive and significant since November 1. So overall, these results suggested that PwDs in many counties are facing a multiple jeopardy based on the convergence of their disability status with Hispanic, Black, female, and to a lesser extent, poverty status that could be amplified by higher COVID exposure in their counties, as well as other disadvantages that I could not examine in the analysis. For example, Hispanic PwDs in El Paso County, where I live, often include undocumented immigrants who are not eligible for health insurance. So anyway, as I concluded in a recent article, these intersectional inequalities clearly emphasize the need for better data and more geographically detailed analysis to better understand the adverse impact of the pandemic. And so the next step was to expand or extend this work in 2 different directions. Number 1 was to move from cases or deaths to more comprehensive measures of COVID vulnerability, indicators that capture response and intervention in these counties, how infections are spreading, as well as public health infrastructure that already exists in the county to deal with the pandemic. So after a review of the literature, I decided to use a new county level measure called the PVI that was developed just a few months ago through a collaborative effort led by the NIEHS and now used by the CDC also. So this PVI is based on 12 factors or indicators organized into 4 domains that you see here, which clearly extend beyond COVID incidence or infection rates. And here's the general article in Environmental Health Perspectives that describes the methodology and data sources in detail. But maps based on the PVI can now be viewed or downloaded, I guess, through the NIEHS COVID dashboard. So this PVI score for each county essentially is based on the 12 indicators that you see here, and each indicator comprises multiple variables from multiple data sources. And as you can see in the example of a very high PVI county, this is St. Francis, it includes a lot more than just COVID infection rates. These indicators cover intervention testing, social distancing, as I mentioned, health infrastructure such as availability of hospital beds, even environmental factors such as air pollution. So I kind of, using the same methodology and approach, I calculated the overall PVI score for each county and use it as a dependent variable in the same set of GE models that you saw earlier. I did notice slightly different results and stronger positive relationships with social disadvantage. Even the overall PwD percentage, which was negative when I was using just COVID incidence, you'll notice how it's higher in counties with greater PVI, unlike what I found before. So higher PVI was linked not only to higher percentage of minority and female PwDs, but also higher percentages of those who are lower economic status. So again, beta values for both poverty and unemployment rates are positive and significant in all time frames. So how we measure COVID vulnerability in terms of incidence rate versus this PVI score did make a difference. And remember my second, I guess, method for extending this work was to downscale the analysis or move from aggregated county level data to more disaggregated household or individual level data. And here I ran into some interesting roadblocks. Now, a popular resource for household level data for COVID is this weekly household pulse survey conducted by the census that a lot of researchers, including my colleagues here in sociology, are now using. It provides a very useful household level information on a wide variety of impacts, as you can see, employment, food, housing, education, and even well-being. And this is available for every week, starting from May of 2020. But when I started exploring the variables, I was not able to find disability status of survey respondents. So this omission prevents us from analyzing these specific impacts for disabled residents. And also important to analyze, I think, individual records on COVID-related cases and their outcomes. And case surveillance data can now be obtained publicly from the CDC and other sources. And as you can see in this example of the CDC's public use data set that a lot of public health researchers are now using, the columns available include age group, sex, race, and ethnicity, but there's nothing on disability status. So clearly there is a data injustice of sorts here, and implies that COVID-related government-sponsored surveys and data collection systems really need to include disability status in addition to the other existing indicators they already have to address this data injustice or gap and better understand how the pandemic has affected PwDs. Now, to deal with this issue in the short term, I'm now planning to use survey data that will be collected later this month for a different study funded by my recent NSF Rapid Response Award. And this project actually focuses on the combined impacts of both COVID-19 and the Texas winter storm that happened just a few months ago. But since I was involved in designing the survey myself, I was able to include survey questions on both disability status of household members and also how the pandemic has affected them. Almost 50% of the households in our sampling frame actually live in public housing projects that are designated for elderly and disabled residents. So I'm really hopeful that this survey data will provide new knowledge and household level insights, that will allow me to kind of address these research questions that I began my project with. And finally, I'm also, with the help of a PhD student, in the process of building a geospatial resource or dashboard that utilizes the disability data that I compiled for this project at the national scale. And the working title or acronym is DVD, which probably still needs more work. But the idea here is that this could serve as a useful educational tool for teaching and learning about the geography of disability in the US that I can use in my classes I teach. But it can also serve as an interactive database that helps a wide range of stakeholders identify and support socially vulnerable PwDs who might need special assistance during an actual disaster or health emergency. And I don't really have time to discuss the details. I know we're running late today, but it does have two main components or data layers. For the first component, each county or tract receives like a percentile rank-based score based on type of difficulty and percentage of PwDs. The second component is based on 3 dimensions of disability-specific social vulnerability, economic, demographic, and minority status, calculated using relevant variables from the ACS. So the idea here is that each county or tract receives a percentile rank for each of these dimensions, as well as an overall social vulnerability score that combines all 3. And here's kind of the prototype version that's available on this website based on county level data for right now. It does cover all states, including Alaska and Hawaii. And for the first component or map layer, counties are ranked or classified based on the overall disability percentage. But we can select any county using the search tool here or by just clicking on the county, such as El Paso County, Texas, for this example. So on our left, we can view monthly data on COVID cases and deaths and the PVI score that I mentioned earlier, and how these have changed over time since last year. And the pop-up window for this layer shows types of disability. You have the raw percentages and the percentile ranks, which allow comparison with other counties in the US. El Paso County, for example, with a score of 0.33 is almost in the bottom 1/3 in terms of this overall disability percentage. And for the second component or map layer, counties are ranked and classified based on relative social vulnerability of disabled residents. And here, looking again at El Paso County, we can view the same COVID-related variables on the left, but this pop-up window shows a separate percentile rank for the three dimensions, economic, demographic, and minority status, and of course, the overall score that combines these three dimensions. Again, useful for comparing with all counties nationally, and this score 0.77 is quite high for this county, in the top 25%. And the individual variables used to derive these indicators or ranks can also be viewed in the same window. Again, of course, my goal or my next step is to link this dashboard as well as the data sets, metadata, and documentation to the CyberGIX Geospatial Hub. And my final slide contains a list of papers and presentations related to the project, completed or in progress, as well as some media outlets that have cited my article in the Disability and Health Journal. But that concludes my talk, and thank you all for listening and watching.
Thanks so much, Jay, for that wonderful talk and for addressing this very important topic for the audience. Again, please feel free to use the Q&A feature to type up your questions. We will leave the interactive Q&A at the end of the second talk. The second talk, as I introduced, will be given by Dr. Daoqin Tong. Daoqin, if you are ready, take it away. Thank you.
Thank you, Salwan, for the nice introduction. Can you guys see my screen?
Yes.
Okay. Yeah, thank you all for coming today. And I'm going to talk about some of the preliminary results supported by Geospatial Fellowship Program. And I have my colleague, one of my graduate students, Shaiting, working with me on this project. Mainly, this project is investigating how the COVID-19 pandemic has impacted the food access. So here's the outline that I'm gonna use for today's presentation. So I'm just first to present the problem, then I'll talk about my research questions, and then what method I'm going to use to answer my research questions and present result and summary and discussion. So today, the most important topic that I would like to focus on is related to food access and food insecurity. So even before COVID-19, food insecurity and food access has been a really serious issue in many parts of the world. So I just listed some of the figures here, some of the data information here. So people have identified a few reasons or factors for food insecurity issue. So the number one factor is related to poverty. And then some other areas could be related to high food prices and unequal food distribution. And in some places, even food production. So there might be insufficient food production in certain places. So if I come back to the United States, I would imagine in the country, so we don't have the issue of food production. So we have a sufficient amount of food production, but a lot of the food insecurity issues related to food access and food distribution. So as I said, even before COVID-19, so there's a significant amount of households in the United States that have a food insecurity status. So when I think about or talk about impacts of COVID-19, so the impacts are obvious. So there's on the one hand, we have a high unemployment rates. So some studies have shown that more than 36 million people filed for initial unemployment benefits. And because of the unemployment, so a lot of people, actually a lot of families were pushed into food insecurity status. And on the other hand, in terms of food access, we have this, especially during the initial stage of COVID-19, we have the social distancing requirement. So this may affect the way people obtain food. And if I think about the vulnerability of the entire food system, so our food system, some people originally, especially some customers originally will always think, okay, there's always items or food items in grocery stores. There's never been being a status or situation where we couldn't get enough food. So people start to think about vulnerability of our food system because we have supply chain disruptions. For instance, during COVID-19 disruptions due to two major food packing facilities, and also because of COVID-19, there's during certain period there's serious labor shortages in the agriculture system. And then if I think about food insecurity issue, and then there's food assistance programs or resources, and during COVID-19 those resources are even more strained than ever. So this is a study conducted by the Hamilton Project. So just initial stage of COVID-19 in April 2020, the study found that there's more households with food insecurity status, especially households with children under 18. So coming back, because I'm Phoenix based, and Phoenix in local areas, food assistance programs like a school, meal programs, for instance, a lot of those programs were shutting down because of the COVID-19. So my research question will be mainly about the impact of COVID-19 on food access. So as I mentioned, so there's economic stress, and also we have new rules for obtaining food because social distancing and various other factors. And we also think about, okay, because COVID-19, a lot of people have changed their lifestyle and also their travel behavior. So a lot of people choose to work from home, and how this will actually affect food access or food shopping or obtaining behavior. And how does those impacts vary in different regions or areas? So in this study, because if I think about the entire food system, you have conventional food systems and local food systems. So conventional food systems, you can think about supermarkets, because those components involve large-scale food production and distribution. While local food systems, in local food systems, we produce food and distribute and consume food in small geographical territory in local areas. So later I will talk about this. During COVID-19, so a lot of local food production sites were shut down or have very limited access. So in this study, we are going to mainly focus on conventional food system, access to conventional food stores and or supermarkets or grocery stores. And before I talk about the data and analysis we actually worked on, so I would like to just briefly talk about relevant studies. So during COVID-19, a lot of studies have been conducted to look at various aspects related to food access or grocery shopping. So we just list a few of them or grouped them into a few categories. So one category is related to panic buying. So during the initial stage of a crisis, especially, so in our case, it will be COVID-19. So people tend to have this panic buying behavior. So a lot of times this is caused by anxiety or the fear of future storage. A lot of times maybe there's no food shortage, but because people are worried and afraid of future food shortage. And also there's a number of articles that study the changes in diet habits. For instance, some studies predicted that COVID-19 may deteriorate nutritional and health status. And because of financial constraint, people may reduce or might have reduced their grocery budget. While some other studies indicated some people actually eat more healthy food. So they tend to eat at home more and they tend to cook a more healthy food. So in terms of food shopping, so because of shutting down of restaurants, so a lot of people use grocery store as a main food obtaining channel. And again, because of social distancing and the consequence of COVID-19, online grocery shopping has been widely used. So a survey actually has indicated that just in April 2020, online grocery sales increased by 37% than those in March. And a lot of households, so in this case, the survey indicated about 26% of the households with no previous online shopping experience would said that they would actually try online shopping. So, and in terms of studies on grocery shopping during COVID-19, so a lot of studies use questionnaire survey. So they looked at different kind of aspects of food access. So they looked at grocery shopping behavior. For instance, they found that a lot of studies found that people tend to spend more on groceries and meals compared to other errands during COVID-19. And young and high educated customers more likely to use online shopping. In terms of diet habit, there's both ends. There's increased consumption, both like fresh food and also the canned and fast frozen food during COVID-19. So I guess some of the reasons might be because people don't use restaurant that often. So some people may cook more food at home, or maybe some other people may use fast food or canned food. And also other, a lot of studies look at attitude and the perception. So they've looked at anxiety or sensitivity to shopping environment. And some studies suggested that there's decreased confidence in food system resilience. So as I mentioned earlier, so regional people thought, okay, our food system's very resilient. There's always food items available in our supermarkets. But during COVID-19, sometimes certain food items might not always be there, or maybe there's limits in terms of how much you can buy. And all of the studies, there's very minimal attention paid to travel behavior associated with food shopping. So as I mentioned earlier, COVID-19 has significant change in people's lifestyle and activity travel. So it's not clear how such changes may affect people's food shopping behavior, especially during COVID-19. So what we are going to study in this project mainly about how to examine food shopping visits to grocery stores in 4 large metropolitan areas. So they are Los Angeles, Dallas, Phoenix, and Seattle. So those are in different parts of the region and representing. So later I will talk about, we are going to look at more places. Those are just the first 4 sets of metropolitan areas. And we look at 2 time periods. The first time period is just April and May in 2020, just the initial kind of stage of COVID-19, how people react to COVID-19 by visiting grocery stores compared with April and May in 2019. And we obtained demographic socioeconomic data in those 4 metropolitan areas. We also obtained grocery store visit data from SafeGraph. I know a lot of our fellows have used the SafeGraph data. So here I'm going to just briefly talk about the data. So this is a place food traffic and demographic aggregation data that answer a bunch of questions. So some questions relate to how often people visit store, like a point of interest or a place, and where they came from. So in terms of where they actually have already aggregate at the block group level. So we got the data as aggregate at the block group level, and where the POI they went and more. So again, so those POIs, we have the location information, latitude and longitude. And so this is just a list of the items we obtained from SafeGraph data set. So here, let me actually activate my. So this NAICS code is related to what types of business the POI is, point of interest is, and what brand this is, and the amount of visits, and which census block groups those visitors came from, and some other. And this last one is related to what other brands or places those people visited. And we actually 5 categories, I believe. Yeah, so the first one is the convenience stores. So for instance, 7-Eleven, Circle K, and larger retailers, Target, Walmart, specialty food stores like Trader Joe's and Sprouts, and supermarkets, just traditional grocery stores like Food City, Fry's, Safeway, and warehouse clubs like Costco and Sam's Club. And this is just a number of grocery stores in different places. So in LA, because it's much larger, so you have more in total amount of grocery stores, and followed by Dallas, Phoenix, and by Seattle and Phoenix. Seattle and Phoenix have almost a similar amount. And in terms of distribution of those food stores among those 5 categories, convenience stores, in terms of number, convenience stores accounts for the largest proportion. So about, if I'm looking at those 4 metropolitan areas, about 70% of those stores are convenience stores, then followed by supermarkets, and then other types of stores. And this is just the distribution of those stores in those 4 metropolitan areas. So I'm going to briefly skip that. So we also do some data pre-processing, because SafeGraph data, the data is based on some samples. It's not really about the entire population, the store visit about the entire population. So this is based on their mobile phone users. So we did some calibration there, and also we aggregate the visits based on block group level. So I don't think I have enough time to go into the details. Then this is just the grocery store visits in those 4 metropolitan areas. So you see in 2020, so in 2020 compared to, so this is April and this is 2019, compared to 2019. So in some places you see decrease. This is the LA significant decrease, but in some other places, Dallas, for instance, and also Phoenix, you do see increase in the amount of visits, and then followed by some other patterns. So there's no like consistent patterns across all 4 metropolitan areas. In some areas, you do see decrease in terms of the amount of visits, but in some other areas, you do see the increase. And this is the proportion of visits among their 5 different types of stores. And so you'll see a significant amount to convenience stores, and then supermarkets and the larger retailers. Supermarkets, this one, and then larger retailers. And then we also look at the average travel distance, because you think about during COVID-19, people may actually choose a different store, or maybe they go to a store that's further away to obtain certain items they couldn't get from some stores close to their places. So we also looked at average weighted distance from home to grocery stores. So you do see some consistent pattern here, just different from the overall store visits. You see, so in 2020 April compared to 2019 April, you do see a slight decrease in terms of the average weighted distance. And then in May, actually, people start to travel a little bit further. So there's a slight increase in May. And this is just the travel distance to different types of food stores. And you see, although we have a lot of convenience stores, you think about, so as I mentioned earlier, so we have the most amount of convenience stores distributed in all those 4 metropolitan areas, but we do see a much higher distance when people visit those stores. You do see a much higher distance to those stores. So one of the things that we thought is that people do not necessarily go to the nearest convenience stores, because a lot of times maybe they are on the way to somewhere else and grab something from convenience stores. And then we also then run some model to examine the significance of some like shopping travel, some travel behavior, and also other factors related to food environment and socioeconomic demographic factors. and also the disruption of COVID-19. So we adopted this segmented linear regression model to investigate how COVID-19 as an intervention, the impact of COVID-19 as an intervention on food access. So let's look at the model here. So this is the outcome at time t. So for instance, maybe this is like a certain time period, could be April and May, and then it could be before COVID-19 and after COVID-19. And then you have a pre-intervention status and the one coefficient associated with that. And then intervention, in our case, intervention will be COVID-19 here. So you would imagine when this is intervention, then this will actually, if this is significant, you will have a different intercept here. And then also post-intervention, some variables are related to post-intervention and whether we have a different coefficient and stuff like that. And then this is a summary statistics of those variables we look at. So, okay, I forgot to mention those dependent variables. So we ran two models. The first model dependent variable is the overall store visits. And the second is average weighted distance. And we look at travel behavior. So in particular, we look at the trip chaining behavior. So for instance, a lot of times we actually go to, say, I visited Safeway, but maybe I visit Safeway on the way back from my work, or I combine Safeway visit with maybe a Home Depot or some other store visit. So we tend to combine multiple stops together. So we call this trip chaining behavior. So we looked at trip chaining behavior before COVID-19 and during COVID-19. And then we also have a group of food environment variables. So how far it is from some specialty food store, and those five the store categories I mentioned earlier. So specialty food store, large retailers, and some other stores. And then some socioeconomic demographic variables, population, senior people, and young people, and with the Hispanic and income level, car ownership, and also education level. And also because we have like April and May, there may be change due to just the season, just a different month. So we also look at that change and also the intervention of COVID-19. So this is a summary descriptive statistics of those variables. Just briefly go through that. Okay, let's look at the result. The first model is dependent variable is grocery store visit. And you'll see here, so as we actually mentioned earlier, so COVID-19 as an intersection, so at the intervention. So you see, so in some areas in Dallas and Seattle, you see this has a negative impact. So it means after COVID-19, during COVID-19, you do see the reduction in store visits. But in some other areas, you do see an increase. So people, maybe this is a panic buying behavior. People tend to visit more stores and buy more stuff there. And also trip chaining. Let's look at this trip chaining category. So before COVID-19, and both before and during COVID-19, we have positive significant coefficients. So that means people tend to combine, people who do trip chaining tend to visit more stores. So in other way, people tend to combine store visits together. And if I look at the standard coefficients, those during COVID-19 tend to be a slightly higher, except for LA, slightly higher than before COVID-19. So this trip chaining behavior is more often than before COVID-19. And in terms of food environment, we have a positive effect with, so in terms of distance to convenience store, we have positive effects. So it means if you are closer to a convenience store, it's less likely you are going to do more store visits. So because the distance is just the further away you have more distance, and it's closer, then you have less visits. So on the other hand, if you are closer to larger retailers in some cases, and supermarkets here, you tend to do more store visits. So if you have, for instance, if Safeway is very close or Fry's is very close to your place, you tend to visit more stores. And then population, we also control population here. So the more people, of course, you have more visits. And then so another thing I would like to look at is this income variable here. So the higher income, we also see an increase in the amount of visits, and a negative impact affects relationship associated with car ownership. So if you know if people have no cars, they will actually tend to visit. They tend to visit stores less. And also, high educated people have less store visits as well. And also in May we have a decreased amount of visits. So second model looked at dependent variables average weighted distance. So as we mentioned earlier, significantly, so during COVID-19, so people have decreased their travel distance. And also there's also factors associated with trip chaining and the food environment. So I don't think I have enough time, but I will summarize this in my summary and discussion page here. So overall, my research shows that there's changes in store visits. Is there some areas, some regions, we do see increased store visits, for instance, in LA and Phoenix, while there's decrease in other areas like Dallas and Seattle. And there's reduced visits in neighborhoods with a high percentage of Hispanic, Asian, and with people with no vehicle access, and also people with high education. And travel behavior, we do notice the significant impact of trip chaining. So significant trip chaining is significant both before and during COVID-19. People tend to combine grocery shopping trips more often during COVID-19. And people tend to travel less if they use trip chaining, more likely to visit stores far away. So actually, people with better food environment tend to travel less, and people with high educated people also tend to decrease their travel during COVID-19. So if I compare different types of stores, convenience stores, there's a reduced preference of convenience stores and an increased preference of, in some areas, of large retailers and supermarkets, in some areas, warehouse clubs. In future, so as I mentioned earlier, so we just look at 4 metropolitan areas. We plan to analyze additional metropolitan areas, including New York City and Chicago. And we would like also to combine those data with survey data we've obtained during COVID-19 to better understand the reasons behind those behavior. And I would like to especially thank Geospatial Fellowship Program for the support, and also our fellows for their insightful discussion and support. So I'm gonna stop here. Thank you.
Thank you so much, Daoqin, for sharing your very interesting study. We have, I think, several questions in the Q&A. Maybe I could invite Jay to address some of the questions directed to you.
Sure. I think one of the questions I'm looking at right here from, I'll start with the first one on the list, right? From Maction, right? Yeah, it's about the intersectional analysis and why the beta values are potentially higher for women when I disaggregated the PwDs in terms of biological sex. And that's a really good question in terms of why that's important, because when I initially submitted my journal article, I did not break it down in terms of gender or sex. And it's one of the reviewers then encouraged me to do that and pointed me to this whole literature on the female disability disadvantage and how women with disabilities have been documented to face more discrimination and difficulties in access to education, employment, housing, healthcare, as well as gender-based violence and abuse. So there's interesting literature. And again, how it turned out to be at the county level. I wasn't expecting that to happen, but I did look at some of the health indicators and social indicators for women in these counties kind of matched up with that. So there is some correlation with the status of women, both health and social, in those counties, and high percentage of those with disabilities, that did overlap. So that would be my answer, beyond, of course, additional exploration, which I haven't done yet beyond the county level analysis. Okay. And a question from Naomi about how I calculated incidence rate at each time period, and whether they're based on monthly new cases or they were cumulative. And I think the answer is I did try both, but in terms of what I presented here today, it was collective for that particular date, all cases, starting from, first day they were recorded to either May 1st or November 1st or August 1st, etc. What I presented was collective cases, so they were always, going up or increasing in number. Hope that answers your question, Naomi. And I think, is there any other question for me? I think the rest are for Daoqin, right?
I think Michael Child had very good question. His question is, could you say something about uncertainties in the safe graph data and effects on results? Yeah, we do see some potential errors in the data set, especially for areas with very minimal population. So when we calibrate the data, we noticed that after the calibration, especially in those areas with very minimal population, we noticed that the amount of people we calibrate is much more than the population we got from the U.S. Census Bureau data. So I think there might be issue with some. Again, this is probably a very common issue for places when you have very few sample or maybe very minimal population. And we also noticed there could be inconsistency in the PwIs as well, because we also matched the PwI data, which is in another study, we try to match the PwI data set from CIFRAF data with some other data sources. We do see some inconsistency. So while we're trying to combine, so one of the things that we try to do is just to combine different data sets, but I'm still working on how to address those issues, because the data, we have no control about the original data. What we got is just the aggregated data. But that's definitely a good question, because nowadays a lot of people actually use safe graph data for a lot of studies analysis, and we just take the results. We never thought about what the impact of the uncertainties in the data set. And then Naomi had a question about, in your research, did you find a relationship between this severity of lockdowns and type of food locations visited when comparing different locations? I have not, but that's a very good question. Originally in our model, we didn't include this in our analysis result. We did look at different, so in different stores, we did look at whether certain type of stores have extended or different just different rules in terms of who can visit. For instance, certain stores offer extended or special hours for senior population groups. We have not been able to incorporate those detailed kind of conditions in our model yet. But that's definitely a very good suggestion and comment. And Daniel had a question about, you may have stated, but other than convenience stores, did people appear to be traveling to food purchasing sites mainly from home? Did this change between 2019 and 2020? So in my previous studies, I did notice that people do not always originate their food shopping trips from home. They may combine, as I mentioned, so food trip chaining could be a very, very important factor affecting people's food shopping. So, in our study, we were not able to tell whether people originate their trip from home. directly to the store to do the shopping there, which is assume like this store is just on the entire trip. Whether the store is the first stop or a lot of times it's the last stop, but we don't know which stop it is, or is it just a home-based shopping or not? We don't know. So a lot of times we have to use surveys and some kind of maybe GPS data to tell more about the details, travel details. But it would be nice if we can have that information. So unfortunately, for now, we just know how far it is from the census block group to that particular store that the individual customers visited. And Shane had a very good question. So maybe you want to show the variance of those trend lines comparing 2019 and 2020. That's a very good point. Currently, we just lump them together. There might be significant variances in different neighborhoods. That's a very good point. I think that are all the questions for me. Did I miss any questions?
Daoqin and Jay, many thanks for sharing your insights. I think you are quite efficient sifting through the questions in the Q&A because we got a slow start today. Now we passed the hour. Colleen or Jayajit, if you might help promote the participants into the Zoom.
Yes,
Or
we can
right.
do that. If you don't mind, I will stop the recording so everyone feels okay sharing their screen and all of that. So let me pause the recording. Is that okay?
Yeah, sounds good. Thanks, Colleen.